Hey friends, today we're going to be discussing patient assessment and care planning. We're going to be talking about how we do that as a comprehensive whole patient family approach and how we do that collaboratively as an IDT team, as well as bringing the patient and their family in to collaborate on that care plan with us. On the next few slides and in this training today, you will learn how we use the care plan as a tool to further improve the patient experience with us and how we adjust that care plan throughout the patient's stay with HonorView Hospice to ensure that their needs, their family's needs, and any perceived problems are addressed. So we start with the purpose of the patient assessment. The patient's assessment is to really identify the needs of the patient and their family or their caregivers. We use that to then develop the individualized care plans. We prioritize problems, interventions, and then we use ongoing assessments to evaluate the patient's progress, not just with their problems, but with their own goals and how those interventions that we've set into the care plan are really working towards getting those patient-centered goals met. The assessment is kind of the core that we use as clinicians to determine how the patient is doing, not just physically, but emotionally and spiritually as well. Everything starts with a good, solid assessment. On the next slides, we're going to talk about the types of assessments that we use in planning the care plan. So what are the components of the assessments? What are we looking at? Obviously, we're looking at the patient's clinical, physical assessments. So we're looking at their medical history and their diagnosis. So we're digging deep into that chart and we're looking at where were they prior to coming onto our service and where are they now. We're looking at their physical symptoms. We're looking at all of their current body symptoms. We're looking at their pain. We're looking at their functional status. We're also looking at things that are not just physical about them, things that would be like nursing or home health aid related. We're going to look at their living environment and their activities of daily living. What does that look like? How do they do them? We're going to look at their nutrition, their hydration. We're going to look at their spiritual and emotional well-being, and not just of the patient, but as the family unit or the caregivers, the people who are there with our patient. We're also going to look at what does that social support network look like for that patient? Is it a caregiver? Is it a facility staff? Are there family or friends involved? And how are they coping spiritually and emotionally? In addition to this assessment, we're going to be looking at the goals of the care. What does the patient, the family, the caregiver, the facility staff want to do for this patient? What does end of life or pain management care look like for this patient and their support system? We may also assess medications that they are taking or that they're willing to take or that they don't want to take anymore. We might also look at different interventions that the patient is willing to accept as part of their care plan. So now we need to look at how do we assess all of those things, right? Because that's a lot of stuff. So we need to look at how we gather that information. So the first thing that we're going to do is just physically look at the chart. We're going to gather that stuff together. So we're going to look at the medical chart. We're going to review the records. We're going to review the medication list. We're going to conduct an interview. We're going to talk to the patient. We're going to talk to the family. And then we're going to do a thorough physical, mental, spiritual, emotional supportive assessment. And that's going to include laying hands on the patient if you're a clinical provider. So nurses, we're going to do a physical assessment. We're going to touch them. We're going to take vitals. We're going to check them out. And then we're also going to talk with the IDT team, right? We're going to get together as a group and we're going to talk about it. And then we're going to talk to the patient and the family and, see how they feel about what we've learned about them. So just that information gathering, the combing through the charts, all of that is really, really important start to our assessment. Then for the nurses and the CHEJs, we're going to look at physically what is happening to this patient, right? We're going to check vital signs, obviously temperature, pulse, oxygen saturation. What does their breathing look like? What does their blood pressure look like? What does their pain look like? Pain is typically, we always say it's the sixth vital sign, right? Does it hurt here? Does it hurt there? Does it hurt when you're moving? Does it feel better when you're resting? All of those things. We're going to do a thorough medical examination. We're going to look for changes in their height, their weight. We're going to look at their MAC, right? Their arm measurements. So we're going to look at muscle wasting. And a lot of times we're looking at patients who might not be able to physically or verbally tell us. So we're going to have to touch, we're going to have to talk to other people. And we're going to have to do alternative ways like the FLAC or the pain ad to get them to really express what's going on with their bodies. We're going to have to do functional status assessments. So watching them or helping their caregiver perform ADLs to really be able to tell where their physical capabilities lie. Right, so we're going to have to go in as clinical providers and nurses and aides and assist with those ADLs, assist with turning them in bed to see really how physically capable or incapable are they now versus where they were. And obviously this is going to add to our depth of knowledge about this patient. And then again, that pain assessment is so important, right? What kind of pain are they having? If they can, have them describe it to us. Where is it? How bad is it? And what kind of impact does that really have on their ability to live their life as they want to? So then, obviously nurses and aides are going to get into this, but really deeply social work and chaplains are going to get into the emotional and psychological assessments, right? We're going to be looking at emotional state, mood, anxiety, depression, but also what brings them joy, what brings them peace. How are their coping mechanisms and stress management, not just for patients, but for their caregivers, for their support network? What helps? Right? What brings in a sense of empowerment or independence for patients? How do our caregivers and our support system find resolution and find coping and support in the day? Who's supporting our support system, right? And what does that support system look like? Does the patient rely on one single person and that person has no one to then fall back on? How do we help everybody who's attached to this patient to find support? So we have to start in and assess that. And sometimes just sitting there and listening and talking with them, as well as observing that support system in action, can be really, really helpful for this whole group of people. So part of this social assessment is looking at the living situation itself. So we're looking at, is this a house? Is this a facility? Are we in institutionalized care, like a skilled nursing or a hospital? Asking whoever is caring for the patient to give you a tour, right? Take you around, let them show you what's going on in the house, let them show you what they're doing, give you a demonstration of how they do the ADLs or how they care for the patient or care for themselves. Can be really eye-opening to what is going on in the house, because people will tell you one thing, but when we see it in action, it really gives us a depth into how they're actually doing the care. Again, observing that care network in action with the family, the friends, the caregiver, outside ministry, pets, anything that is happening. And again, a lot of this is just spending time getting to know people, right? Social workers are really great with financial resources. So I know this is a big one. Do they have insurance? Do they have benefits? Do they have government entitlements? And then of course, what are their expenses? And having them just show you, hey, these are the bills. These are, the checks that we get. This is what we have available. All of that is part of the social assessment and part of the things that we're going to look at to take and put into that care plan. And then when we get into the spiritual assessment, right, we're not just looking at, Do you guys have a religious preference? We actually need to get a little bit deeper, right? What are the patient or their caregiver family's spiritual beliefs? What do they think is going to happen when they die? What are their ideas about the meaning and purpose of life? Do they need life review? Do they want any of this for themselves or their family? Do they have support for their spiritual needs? And then additionally, we have chaplaincy and spiritual care. How do we come in and support them in their life and belief journey? And then, of course, we've tied a lot of everything else into the caregiver, but we really need to do a deep dive on the caregivers themselves, right? How are they doing physically, emotionally, spiritually? Are they able to provide care? Are they able to provide emotional support to the patient, right? Our patient, without tying that into their own bereavement, right? Are they a bereavement risk? One of the best ways that I have found to do this is really just setting up a time to meet them outside of their care space, right? Meeting with them privately and getting to know them and just having a talk with them where they're free. They're free to speak because a lot of times they may not want to talk about this in front of the patient, and that's totally okay. So again, really just observation and getting to know people is the best way to assess them. So again, a caregiver assessment that is separate from the patient's assessment with respect to the caregiver. So now we have all of these assessments that we've done as a team, individually and together. What are we going to do with that? Well, we're going to use all of these assessments to create that personalized care plan that we're looking for to guide our care for this patient. So the care plan is an individualized roadmap for patient care. It tells us when we go in, what are we doing here each time we visit this patient? Because as much as we would love to just go and be with them, we have to have a purpose of care. So all of these assessments really beautifully tie into identifying problems for the patient, whether they're nursing and clinical, the patient has a wound and we need to address that, or, social, gosh, the patient really has a lot of expenses and we need to help this caregiver find ways to pay for them, or spiritual, right? The patient is having a lot of questions about what happens to them after they die and they're questioning their faith. Or they're caregiver related, right? The caregiver has a high bereavement risk. They've lost a lot of people in their life. So we take those assessments and we form our care plan. So the care planning process as a whole basically, again, starts with that assessment. What do we look at as a team? And we say, hey, these are kind of some issues that we've identified in the patient's life that need addressing. And then we look at goal setting. We talk to the patient and the caregiver and we say, hey, these are some areas of opportunity that we have found. What do you guys see as your goals? So I will just use my own experience here because I am a nurse, I am a clinician. So we will talk about wound care. If I go to a family and say, hey, we have a wound, what are your goals for this wound? And they might give me a goal that says, hey, we would like that wound to heal. So we would talk about some interventions, which would be strategies to, get to wound healing. We would talk about realistic goals. So maybe if this is a very large wound, the wound may not heal. So we would talk about, again, realistic goals. We would then implement the interventions that we have agreed on. And then regularly during my nursing visits, we would obviously implement the interventions. We would evaluate how those are going. And then usually every 2 weeks at IDT, the team and I would be discussing how those are going. And I would be returning back to that patient's home and we would be talking about how that wound is adjusting, what our goals should be. Do we keep the same goal of healing that wound? Do we set a new goal? Do we start new interventions? And do we implement them? So that's kind of that care planning process in a picture of obviously a nursing related goal, but you could expand that process to any goal with any problem, with any interventions that you would do. So your care plan components, right, the actual individual pieces are your patient information, which is obviously all of that assessment information, your goals and objectives, and your goals should be specific, measurable, achievable, relevant, and time-based, which is a SMART goal, which for a lot of our patients really needs to be something that is realistic and achievable, right? And I like to focus when I'm talking with patients and families on that realistic and achievable, because a lot of times we're looking at patients with a shorter time frame with us and in our care, and sometimes they have really, really big goals, and so we need to find a way to make those goals achievable for them. The rest of the care plan, we talk about our interventions, we talk about our IDT collaboration, how we as a team are gonna be here to support each other and this family. We talk about patient and family education, again, educating that patient and that family about how we're going to help them achieve their goals and how we're going to keep and update this care plan to support and honor their wishes. And then sometimes we have to use referrals and resources, right? If it's a goal that we cannot achieve on our own, sometimes we have to bring in outside support. So when we're talking about care planning, we really want to focus on the collective wisdom, not just of our team, because we are all obviously very educated, very experienced individuals, but we want to honor the collective wisdom of our patients and our families. We want to honor their patient-centered wisdom. Our patient has lived in their body their entire life. They know what they need, what they want, and what their preferences are. So that care plan should be very individualized to that patient. We should honor their patient experience. We want to honor their lived experience. We want to make sure that that care plan is comprehensive to address all of their needs, and that we want to collaborate together, not just as a team in IDT, but obviously with the patient and family, and then again with any outside resources that might help us make sure that we are honoring that patient's needs and goals for care. When we collaborate as an IDT, we want to make sure that we're documenting each visit and each assessment as quickly as possible so that everybody on the team can see what we're doing and can see how we are working towards each goal. Even if I, as an RN, am not addressing social work goals when I am visiting a patient, how that patient is progressing with a goal such as resource finding or moving towards a bereavement goal is going to affect how I address that patient when I am there in the room with them. And a social worker will definitely need to know how a patient is moving forward with a pain goal or an anxiety goal, because these are triggers that may affect a visit with a social worker or a chaplain. We all need to communicate regularly with each other. If I'm not telling as a nurse, a social worker, that this patient has pain when they're being moved and the social worker wants them to sit up for the visit, that's obviously going to affect somebody else's visit. So again, that whole team communication, including team members in the care planning process, documenting everything so that we all know what's going on, super important. Everybody should be attending IDT regularly when it's scheduled for you and your team. We want to talk about these goals. We want to talk about patient progress, and we want to make sure that we are updating patient care plans accordingly. We should be doing joint visits when needed. If a social worker and a chaplain need to go out to support a family in funeral planning or bereavement needs, we definitely want to make sure that you guys are scheduling those visits as a team. If a nurse and an aide need to go out together to do complicated wound care, or the aide needs help moving a patient for a bed bath, we want to be supportive of each other. We want to make sure that we come out together as a team, especially when we need to educate patients and families on a care plan need or to provide extra support and surround them with love. So why do we put so much focus on the care plan? Besides the survey readiness need, right? Besides the fact that Medicare tells us to, the patient is the focus. We are all on team patient. We are all focused on providing amazing care for these patients that are with us through the end of life journey. When we write a patient-focused care plan, it allows us to identify the patient's unique needs. Just because two patients may have a care plan revolving around pain or anxiety or end of life care planning, or they both need to identify a mortuary, or both of them are having some spiritual crises where they are questioning their faith. Each patient is going to have different interventions, different goals for those care plan needs, and we're going to walk different paths with those patients and their caregivers to get to those goals. One patient may have a pain goal of 2 or 3 out of 10 for the same exact pain area that another patient can tolerate a 5 or a 6. One patient might be questioning their faith in a Christian faith, and another patient may be questioning their faith in a Muslim faith, right? So the individualization of patient-centered care planning allows us to take the same base problems, questioning their faith in a spiritual sense, pain, a wound, needing to find financial resources. But we can take that and find individual ways of getting them to their goal, getting them to comfort, getting them palliated in a spiritual sense, in a financial sense, in a physical lack of pain sense. So that's why we focus so much on these individualized care plans, because it makes the care about the patient. It's not just generic care where one care plan fits everybody and we just go and we pop in and we say, okay, your vitals are good, or okay, you have a caregiver here. Okay, I came in and I read you a Bible verse and now I'm going to leave. It really allows us to collaborate with the patient, their family, their loved ones, and find the best way to honor them in this end of life journey. With that said, not every care plan works out perfectly, right? Some of the common concerns and challenges for care plans remain the same across every care plan. There will be patients with complex needs. They may have extremely delicate situations that we have to work with across all disciplines. A patient may have issues with the caregiver or the patient or a facility staff member cooperating with a specific intervention. We may have to do extensive education for staff, patients, community partners, caregivers, or even our own internal vendors on what we need to do to support a patient. And sometimes people are limited in their ability to understand that education. Sometimes that's just a language barrier, right? Sometimes we have to go above and beyond and find resources in somebody's primary language. And in the area of San Diego that we are currently in, sometimes that is Spanish. I've also run across Tagalog and Russian here, but typically a language barrier can be resolved with finding appropriate resources in their primary language. But a lot of times it's an education limitation or a language barrier that causes issues with cooperation with the interventions. Sometimes patients or their families, caregivers have limited resources. They don't have the ability to provide the things that the patient needs. And in that case, we as a team can sometimes come together and assist with that. Sometimes there is a communication breakdown, whether it's in our own team where we did not communicate the need with each other, or sometimes it's a breakdown within the family unit of them communicating with the patient needs. Sometimes it's between us and the patient or us and the care team. Sometimes there are just time constraints, right? The patient is deteriorating faster than we had anticipated, and there is not time to provide the interventions. Sometimes there are disgruntled community partners. They are unhappy with something that is happening, and we have to work through that. Untimely documentation is unfortunately just a fact of life. We aim to have our documentation completed within 24 hours of a visit, but occasionally providers do not have that happen. And sometimes that's not on our end either. Sometimes that is with another provider or with a community partner where we don't have the documentation needed to provide the care on time. And then, unfortunately, we do often have vendor delays. I have seen issues with pharmacies not providing medications, DME providers not providing needed equipment, supply companies not providing things on time. So delays with all sorts of different services can provide challenges and concerns to providing care or implementing that care plan that we've worked so hard to do. So being aware of these challenges or concerns can just help us preemptively work with them or work around them or work through them as we can. All of those challenges and concerns aside, there are so many benefits to collaborative care planning where we work as a team and not in individualized silos by discipline. When we come together as a group and care plan and discuss patient care as a spectrum and not by discipline, the patient has an improved outcome. And by that, we're talking about quality of life, reduction of general symptoms and stress, and they have an improved satisfaction for their care. The patient and their family are more engaged in the care, so they're empowered to come and speak with us or to voice their opinions on their care because they're not just handed our opinions of how their care should go. They are telling us how they feel the care should go, and the care is being guided by the patient with our input rather than the other way around. The IDT collaboration is improved because we are all having input on everybody's plans so that we all are aware of what the team is doing. Nobody is working alone, nobody is an island, and everybody is then supporting each other, which obviously provides better patient support. The patient and family feel supported, included, and honored in the care that we are doing for them. And then we remain obviously in mandatory compliance because we are focused on the patient and we are individualizing these plans of care. In conclusion, we are honoring our patients and their families by knowing what to assess, how to assess it, what we are assessing for, and what to do with that assessment when we circle it into a patient-centered care plan. And when we collaborate with those patients and families to then implement that care plan into their patient-centered care, that is the whole purpose of honoring them and their care with hospice. So I really want to thank everybody for taking the time to listen to this training today. We will be doing individualized discipline care plan training, but this is designed to be an introduction to how we care plan. If you have any questions, I would love to talk to you individually. I care very, very deeply about care planning and patient-centered care. So thank you so much for your time, and I look forward to working with each and every one of you.